Good. We are live. We are live, everyone. Hello, hello, hello. Happy Saturday. Welcome. And thank you for joining for our special presentation entitled New Year, New Hope, an educational symposium presented by More Than Lupus in collaboration with the author of our favorite lupus handbook, the Lupus Encyclopedia. Not to mention our favorite rheumatologist who answers all of your burning questions on our Ask Dr. T posts, Dr. Don Thomas. He's going to come out here in just a minute. My name is Kelly, and I'm the creator and executive director of the Portland-based nonprofit More Than Lupus. And if you're unfamiliar with More Than Lupus, we are a multi-ethnic, multi-generational, and international lupus community designed by lupus patients to connect, to grow, and to inspire each other throughout the peaks, which are the highs, and the valleys, which are the lows, of our lupus journeys. And I say "our" because I have lived with systemic lupus and multiple lupus overlap conditions since the age of 11. So we believe that every person living with lupus, no matter their background, should be treated with equity and dignity and taken seriously. And it is our mission that patients feel heard and seen and valued. And today's event will spotlight the intriguing new developments in lupus therapies, particularly one that has been getting a lot of attention: CAR T therapy. And we hope the information provided today can be used as a resource that hopefully propels you to have an open and honest conversation with your doctor about the prospect of this for potential treatment in the future. By the way, please make sure that you share this live event on your Facebook page so that people can get connected to community and support and have access to some incredible information and resources that will be shared today. Well, before I bring on my special guest, please allow me to give you a brief disclaimer. Please understand that the opinions shared today are purely for informational purposes and do not replace the medical advice and/or opinions of your doctors. If you're experiencing lupus, lupus nephritis, lupus overlap symptoms, it is important to follow up with your doctor and to seek the treatment that is best for you. Dr. Thomas is a qualified professional. However, he is not liable for his comments today since he is not acting as your personal physician or health advocate. That being said, let's welcome Dr. Thomas. Hello, Dr. T.
Oh, Kelly, glad to be here.
Well, here we are. I am so excited to have you today because ever since the American College of Rheumatology conference, I've been dying to talk to you more about this. It was quite the hot topic at that conference.
Yes.
And I know that you have compiled a lot of helpful information for us to understand what CAR T is and how it is providing hope for a potential future of lower disease activity and even remission for some lupus patients. So I'm going to hand the stage over to you. I have a lot of questions, but I'm going to try and contain myself and keep them until the end. Okay?
So just imagine, Kelly, and everybody watching this, imagine having systemic lupus and not having to take any medications and live your life and enjoy it and not have to worry about that. Wouldn't that just be fantastic? Well, CAR T cell therapy gives that possible hope. So Kelly is entitling this A New Year with New Hope. And I'll just have to say that I'm excited about this possibility of a therapy. I don't know if it's going to be as good as it sounds in the long run, but it sure sounds promising. So let's get started. Back in April of 2021, there was this very sick young Asian woman in Germany who had severe systemic lupus erythematosus, and she was just 20 years old. Hers was so bad it was attacking her heart, the valves of her heart, the lining of the heart called the pericardium, causing something called pericarditis, where she would have severe pain whenever she would try to take in a deep breath. But even worse, it was attacking her kidneys. She had severe lupus nephritis, but also arthritis and also rashes from her lupus. Her kidneys were so bad that she was spilling out over 2 grams of protein per day in her urine, and we call that proteinuria. And just to put that into perspective, normally we should have less than 200 milligrams per day. She had over 2,000 milligrams per day. Her C3 complement level was low. Her anti-double stranded DNA level was high. Both bad things showing bad inflammation from lupus. And she had failed all the therapies. High-dose steroids, a chemotherapy medicine called cyclophosphamide, a strong immunosuppressant called mycophenolate, and her doctors were just at a loss for what to do with her. Well, in the medical literature, there was this therapy that had been used in mice that got these lupus mice into complete remission, and it was called CAR T cell therapy. And so they thought they was try to use this therapy in her. Now, her disease was so severe that in medical research studies in lupus, we use a tool called the SLEDAI. SLEDAI stands for Systemic Lupus Erythematosus Disease Activity Index. Every manifestation gets so many points. The more points, the more severe the disease. And when you add up all of hers, it was 16. All you need is 11 or higher for severe disease. So she was really had severe lupus. They gave her this CAR T therapy. 1 month later, her systemic lupus was in complete remission. Her SLEDAI score was 0 after 1 month. I have never in my life, 30 years of treating lupus patients, seen a therapy this good. So, if we just had our meeting at the American College of Rheumatology in November, and Dr. George Shett, he was her rheumatologist, he gave the presentation on CAR T cell therapy, and he actually showed us her photograph. And this is not actually her, but I found this on the internet, and this looks just like what she looked like after her treatment. Well, they went ahead and used the CAR T cell therapy in an additional 4 patients, and they presented their findings in September of 2022. All 5 of them went into complete remission, drug-free remission. And the patient I just showed you, her drug-free remission was for over a couple of years. So this just seems phenomenal. And this is when it started to become popular on social media. Well, as far as when November of 2023 came up and we had our American College of Rheumatology meeting, several other studies were presented, and a total of 20, and many people don't realize this. We hear all about 5 patients and 8 patients, but there's actually been 22 systemic lupus erythematosus patients who have been in drug-free remission. Another 2 patients were close to remission, and the only reason they weren't in complete remission is that one of them only had 1 month of data, the other one 2 months, and with their particular CAR T therapy, it usually takes 3 months. So 24 patients in remission or close to remission. So what in the heck is this CAR T cell therapy? That's what today's talk is all about. I'm hoping to simplify it for you, make it easy to understand, but I'm also going to throw in a lot of science. I know that some of you are going to want this science. For the other ones, I'll try to make it as simple as I can possibly make it. So what does CAR T even mean in the first place? Well, this is a picture of what the CAR T cell looks like. At the end of the talk, you can go back and freeze it and look at it, or you can go to my website, lupusencyclopedia.com, and just search for CAR T, and you can find a very thorough blog article that I wrote about it. Well, each part means something. The T cell, these are T cells that actually come from the patient themselves. T cells are a type of white blood cell of the immune system that has lots of different things that it can do. For CAR T cell therapy, we're trying to train this T cell to kill B cells that are bad. And so this is the most important part of the CAR T cell. And then the AR stands for antigen receptor. The antigen receptor is the thing that you see highlighted on this T cell. It's actually a receptor is something that combined with something else. And in this particular case, the receptor receives the B cells, the bad B cells of the patient, to try to destroy them. And then chimeric refers to this T cell being a chimeric, and I'll explain what chimeric means. Chimeric comes from a monster, a Greek monster called the chimera. And the chimera, it was made up of the head of a lion, the body and the head of a goat, and then the tail was a snake. And so a chimera is an organism that is made up of more than one different organism. And that's what this CAR T cell is. It actually comes from a couple of different, completely unrelated places. So the T cell comes from the patient itself. We take the T cells out of the patient, and then we engineer them and change them into things that can attack and destroy the patient's B cells. And the blue thing that you see inside of there, that's a DNA that's actually inserted inside of the patient's T cells. And this comes from a virus, actually. And so this is the chimera part of it. It's made from the patient's T cells, but also a viral infected DNA. And this is not the virus DNA itself. It's one that we put into the virus and ask the virus to put into the T cell. Then that DNA, it programs the T cell to make this antigen receptor that helps us identify those B cells that we want to destroy. So what is the actual process? Let's say that you're a lupus patient and you're going to sign up for this CAR T cell therapy. What is actually going to happen to you? Well, first, we would taper your immunosuppressants, and we figure out that we want to give you the CAR T cell therapy at a particular point in time. Well, 3 weeks before that, we want to have you off of all of your medications, your methotrexate, your mycophenolate, your hydroxychloroquine. And if you're on steroids, we want to get your prednisone down below 10 milligrams per day. Well, you're waiting 3 weeks, as far as waiting for the CAR T, there's also always the possibility you could flare up. Well, there was a Chinese group that gave CAR T cell therapy, and their plan is that they would give the patients IVIG therapy if they had flares. IVIG, which stands for intravenous immunoglobulins, is a way that we give gamma globulins and antibodies that help treat lupus, but it doesn't suppress the immune system. So I really like the way that the Chinese group did this. The German group, they only had one patient flare up, and they gave that patient cyclophosphamide, but it didn't interfere at all with the CAR T cell therapy. So people can potentially flare, but we have a way of treating those flares if we need to during that time period. Then 13 days before the CAR T cell infusion, you would be brought into the clinic, and then we would do something called apheresis, where we actually take your blood out, and then we remove and separate the white blood cells from your red blood cells. And we can also call this leukapheresis. Leuka refers to the white blood cells. Leuka means white, from the Greek word for white. And so you can see the bag of white blood cells on this apheresis machine there, right next to the bags of red blood cells as well. And we separate those from each other. And then we take those T cells from the patient, take them into the laboratory, and have them replicate and multiply. Well, also in the laboratory, we take this virus called a lentivirus. Lentiviruses are a way that we can insert a particular type of DNA into your patient's T cells to make those receptors that we talked about. So lentiviruses, they exist in nature. And most of you, or all of you, have heard about the HIV virus, for example, that causes AIDS. The HIV virus is actually a lentivirus. It can identify the T cells of our body, it attaches to them, and then it makes those T cells replicate their own DNA. They make a whole bunch more of the HIV virus, and they destroy our T cells, and that's why the immune system becomes destroyed. But these scientists had this excellent idea. What if we could take that bad viral DNA out of those lentiviruses and insert a good type of DNA that we could teach cells to make that can actually serve good. And that's exactly what they did. They took out the bad lentivirus DNA, and it's not HIV virus that they used. They used a different type of lentivirus. And then we can insert it with this DNA that's programmed to make these antigen receptors that can be placed on the T cells. So then this lentivirus is mixed in with the T cells of the patient. The lentivirus identifies those T cells and it says, oh, I'm going to make that T cell replicate this DNA that's inside of me. The DNA goes inside of the patient's T cells, inside of the nucleus, and then it tells the T cell to make those antigen receptors. Voila, we have a CAR T cell that's made up of the patient's T cells, but a viral infected DNA that makes this antigen receptor that can identify B cells and destroy them. And so what happens next? Well, we bring you back into the clinic and we take these CAR T cells, by the way, in the laboratory and replicate them and have them multiply. And before we give them back to you as the patient, we want to do something. We want to make your white blood cell count go low. The reason for that is that when we put the CAR T cells back into your body, we want those CAR T cells to go throughout all the tissues of your body. And a way to do that is to get rid of as many of your T cells as we can so that this can take the place of them. And so we give you a type of chemotherapy called fludarabine and also one called cyclophosphamide. The doses of these are as shown on the slide. For 5 days before the CAR T cell therapy, we start the fludarabine. So we give it on day 5 before, day 4 before, day 3 before, so just 3 days worth. And then the cyclophosphamide is just one dose 3 days before your CAR T cell therapy. Now this of course sounds scary. We're giving you this chemotherapy to get rid of your white blood cells, but you have to realize that these are also lower in dose than what we would normally give to patients. For example, when we do a stem cell transplantation and give these types of therapies, the fludarabine is usually 40 milligrams over 4 days, and the cyclophosphamide is usually 1,800 milligrams for each time that we give it. So this is lesser doses, and it's just enough to lower the T cells. But nonetheless, we have to realize that this can potentially put patients at risk for infection. So that is important to keep in mind. Fortunately, bad infections were not seen in these lupus patients so far. So then we get rid of your T cells, and then we put those CAR T cells into you or infuse them into you, as you can see here with that yellow bag, infusing it back into your bloodstream. And then those CAR T cells go into your body. These CAR T cells, the way our immune system works is that we want to make sure we have enough T cells throughout our entire body and in the tissues. And so the CAR T cell realizes that there's not enough T cells in your body, so it starts to replicate and multiply, and it fills up your tissues and your blood and your lymphatic system with these CAR T cells, thinking that they're your normal T cells inside of your body. But these are engineered to identify and attack and destroy your B cells. So that antigen receptor that's on the T cell, it can identify your own B cells. And as you can see here, you can see it kind of coming together like a lock and a key. In this particular case, this B cell has an identification on it called a CD19 antigen. Now, antigens are you can think of them as badges, ways that we can identify something. And for example, let's say that I was a foreign invader inside of a giant. My badge or my antigen might be this little badge here, right here. This is Dr. Donald Thomas. This CD19 molecule, it identifies this B cell as being a B cell. And so the T cell sees it as a B cell. It thinks that it's a bad B cell, which it is because it's making bad antibodies inside of the lupus patient's body. And so then when it binds to it in this lock and key method, the inside of the antigen receptor activates the T cell, tells it that to destroy this B cell, and that's exactly what it does. It tells the immune system to destroy it. Well, this is very effective. After anywhere from 2 to 7 days after this CAR T cell therapy, all the B cells in the body disappear, the ones that we program it to destroy after the CD19 CAR T cell therapy. And you have to ask yourself, though, why get rid of B cells in lupus patients? Well, it's very helpful to know how the immune system works in order to understand why we want to get rid of B cells. And let's take a look at it. So, how does the immune system work normally? Well, our immune system is there to protect us. And so, just an example, let's say bacteria getting into our body. We constantly have bacteria, bad bacteria coming into our body. And for example, the pink ones you see on the top there, that looks like streptococcus. The ones on the bottom look like staphylococcus. And on top, on their outsides, are all kinds of proteins and molecules that are only found on those particular bacteria or viruses or germs or cancer cells. And again, we call those proteins or those molecules antigens. It's just a badge that identifies it as such. And so then inside of our body, we have these B cells. We also call them B lymphocytes. B lymphocyte and B cell are exactly the same thing, by the way, just different nomenclatures. One B cell makes only one type of antibody, and antibodies identify antigens like a lock and key. And by the way, we talked about antigen receptors on those T cells. Well, an antibody is a type of antigen receptor. It can receive an antigen. And remember, on the T cell example that I showed you earlier is kind of in the shape of a triangle. And then the antigen on the B cell was shaped like a triangle. It only fits like a lock and key for that, only that one antigen. The same thing with these, that top B cell, it only identifies the streptococcus antigens that you see on the right side of the slide here. They're kind of round in shape. So it's not going to bind to a B cell or the bacteria on the bottom. The B cell on the bottom, it's square in shape. It's only going to recognize the staphylococcus antigen that you see on the bottom. Interestingly, we have over 1 trillion different types of B cells, so that they can identify all those different types of foreign invaders that can come into our body. So it's just miraculous on how that happens in the first place. And then it can tell the white blood cells of the body to identify and attack those bacteria, swallow them up and destroy them and keep us healthy. But not only that, they actually call more white blood cells to come to the area of infection and destroy more of the bacteria. So what does this look like? The streptococcus, when it invades our throat and infects us and it wants to kill us, it wants to actually eat away and live on our own body. You can see when we, as the physician, look inside of the throat, we see all that pus or that purulence. Those are actually the white blood cells going to the throat to protect us. And then we have those signs of inflammation that we get from the immune system becoming active. We get swelling. The tonsils on this person are just huge. They're almost touching in the middle. That's where the white purulence is, or pus that you see. The redness, that's a sign of inflammation as well. Pain. Anyone who's had a strep throat knows how painful it is to swallow. It can be even too painful to even swallow water, and it just got to take small sips at a time. Fever, because of the systemic inflammation, that's a sign of inflammation. And then fatigue and just feeling malaise and like you just feel horrible. Well, doesn't all of this sound familiar? Because this also occurs in systemic lupus erythematosus. Just imagine your own immune system is attacking your own organs, doesn't think they belong there. It actually causes this inflammation, maybe not to this amount of degree, but it is causing this in the organs of your body. And it's partly because of those B cells attacking it. So what does happen in the lupus patient, the lupus immune system? Well, those B cells or lymphocytes, like you see on the left side of the screen, I'm going to call them bad B cells, but in medical terms, we call them, or immunological terms, we call them autoreactive. Auto means self, and they react to the body itself, which we don't want to happen. And then they make antibodies that think that parts of the person's own body doesn't belong there. They think that they're foreign invaders. For example, they might think that the skin is a foreign invader and attack the skin, causing that classic butterfly rash or malar rash that we see in some lupus patients, but it can do this in multiple organs of the body, such as the kidneys, heart, lungs, and brain. So throughout our entire body, we have trillions and trillions of cells, and those cells have nucleus inside of them. And then just think about it. You were diagnosed with systemic lupus, almost all of you, because of something called anti-nuclear antibody. It thinks that your own nucleus is a foreign invader and wants to attack it. You have DNA throughout all of your body. And just think about it. 70% of you watching this have anti-double-stranded DNA, thinks your DNA doesn't belong there, and wants to identify it and attack it and destroy it. And this is not good. And so just think, and when this happens, then you can end up getting the problems from lupus, such as this malar rash, lupus nephritis, and other problems. So just think about it. What if we could possibly get rid of these bad autoreactive B cells, and then we can get rid of those antibodies that attack your body itself? We could possibly help your lupus. So that's the whole idea behind this. If we can destroy your bad B cells and help your lupus. And we actually have medications right now that do that. We have medications that actually do target the B cells. There's belimumab, which is Benlysta, rituximab, which is Rituxan, obinutuzumab, which is Gazyva. These actually decrease the B cell activity in your body to help out. But there's a big problem with all three of these therapies. And that is that many lupus patients don't respond to them. And why is that? Well, one theory is because they work primarily in the blood or the lymphatic system of the body. And the problem with that is that we have B cells throughout our entire body. They're in the lymph nodes, they're in the joints, they're in the heart muscle, and that's where they cause their bad damage and everything. And unfortunately, these medicines, they don't go into those tissues. And we know that because doing biopsies of these tissues in people treated with Benlysta and Rituxan, we can still see those bad autoreactive B cells. So we're not getting rid of all of them in the body. And then plus on top of that, we have to keep giving the medication over and over. If we stop the medicine, there might be not very many of those B cells in the blood, but they're in the tissues and they just multiply and go into the blood where they can cause havoc. So we have to constantly give those medications. What if we could possibly give a therapy that could get rid of them once and for all and not have to keep giving therapy? That's one theory behind this CAR T cell therapy. Well, the German group, led by Dr. George Schett and his partners, they have now reported upon 8 German patients. All 8 German patients had severe systemic lupus, failed multiple therapies, and they gave them this CAR T cell therapy that targeted this one type of antigen called CD19. And by the way, I'm going to talk a little bit more about what CD19 means, so that I'll take the mystery out of that in just a little bit. Well, let's look at what happened to these 8 German patients, and we can show the results on a graph when we do this. So this is a graph of their anti-double-stranded DNA results. 70% of lupus patients have high double-stranded DNA, and double-stranded DNA actually goes to the organs and actually causes inflammation and damage. So if we can get rid of it in many patients, then we're probably going to help their lupus out. These are incredibly high levels. Look at the left side of the graph, starting with 200 up to 6,000. Those are the levels. Well, a normal DNA level, anti-double-stranded DNA, should be less than 40. The higher it is, the more danger it is. And look at them. One of the patients had close to 6,000. Now, when we give a therapy that helps out with lupus, oftentimes we can see that the lupus gets better by what happens to the anti-double-stranded DNA level. And by the way, this doesn't occur in everyone. Some of you have an anti-double-stranded DNA level that just stays that way even when you're in complete remission. And that's because there's lots of different types of anti-double-stranded DNA. But these particular ones were bad anti-double-stranded DNA in these particular patients. Well, they followed them every 3 months. And at the 3-month mark, every single patient, their anti-double-stranded DNA level went down to 0. Folks, in 3 decades of taking care of lupus patients, I have never seen a therapy that can do this to 100% of patients, even just a few patients, 8 patients like this. This is just ridiculous. But what happens after that? Well, they followed them every 3 months. And at the 3-month mark, they would check their anti-double-stranded DNA, and it stayed at 0 every single time. They're still monitoring these patients up to this day, and they'll keep telling us how they're doing over time in the long run. Well, that's just a blood test. We want to know actually how their lupus is doing. And again, remember earlier I mentioned that there was this research tool called the SLEDAI, Systemic Lupus Disease Activity Index, where we can actually measure the severity of someone's lupus. And of course, by the way, you can go to my website, lupusencyclopedia.com, and you can figure out your own SLEDAI. Just do a search for SLEDAI, and I actually show you in my blog post how you can figure it out on your own. Look at the left side of the screen. It goes from 5 to 25. 10 or higher is severe systemic lupus. Between 6 and 10 is moderately severe. And these patients, the vast majority had severe systemic lupus, and a few of them were very, very close to the severe lupus mark. The Asian patient that I showed you earlier, remember hers was 16, so she's the dot that you see right above the 15 mark. So they measured their disease activity, gave them the CAR-T infusion, and then let's see what happens to them at the 3-month mark. At the 3-month mark, 7 of them were completely in remission from their systemic lupus. 1 of them was almost in remission and went into complete remission very soon after that. Then every 3 months after that, they measured their disease activity. They have stayed in complete remission on no medications whatsoever throughout the entire time. Not only that, they measured other antibodies and immunological markers, and what they showed is that all of these things went completely to normal and 0 and stayed that way throughout the entire research study. Anti-Smith antibody. And by the way, when I treat someone with systemic lupus and get them in remission, I really don't see anti-Smith get better or go away completely. I can't say I've ever seen that happen in any of my patients, but in these patients it did. Double-stranded DNA, single-stranded DNA, interferon alpha, which is a cytokine. Cytokines are the way that white blood cells talk to each other, and 80% of our lupus patients have high levels. By the way, if you've ever heard of Safnello or anifrolumab, that's how it works. It decreases the interferon levels. Well, it went to normal in every single patient. It doesn't do that with Safnello. Safnello, it decreases the levels, but it certainly doesn't make them go completely normal, which is crazy. And then the lupus nephritis went to normal as well. Well, when we're messing with the B cells are very important for how we fight off infections and respond to vaccines. So the fear of the researchers was, well, are we putting our patients at high risk of infections by doing this? And are they still responding to their vaccines? Well, they followed their vaccine antibody levels like measles, mumps, COVID, pneumococcus over time. They still had good results or good antibody levels. And that's because they were not bothering a type of B cell called a plasma cell, which I'll talk about in a little bit. And the plasma cells were still able to keep making antibodies, good antibodies, to help these patients out to prevent infections, which is fantastic. So what happened to the B cells of these patients? Well, they went completely to 0. These CAR-T cells destroyed all of their B cells. That sounds scary because we're be putting these patients at high risk of infections. And what we saw is that these B cells did go away, not only the bad B cells or the autoreactive, but also the good B cells as well. They disappeared completely by day 9 after CAR T cell therapy. But then at around day 100 on average, and some of them it was 90 days, some 115 days, their B cells returned. Well, the German doctors, they were afraid that these might be the bad lupus B cells coming back. But no, what had happened is that these were normal B cells. How in the heck does that happen? Well, even though we destroyed the B cells inside of the bone marrow, there's still stem cells. Stem cells are baby blood cells that can actually become any type of blood cell, and they started making normal B cells. The scientists stated that they were resetting the immune system. Just think of that. Can we possibly reset the immune system in our lupus patients? Could this possibly be some type of cure or remission? We don't know. We have just a few years of data so far, but we can all hope that this might happen. But there are some unanswered questions. For example, one question that I have is that one of the patients was positive for anti-SSA antibody. SSA stands for Sjogren's syndrome A antibody, and 30% of lupus patients are positive for this particular antibody. So they have these B cells that are making this anti-SSA antibody. Also, 70% of patients with Sjogren's disease. Sjogren's disease, we used to call it Sjogren's syndrome. It's related to lupus. It also attacks the body, especially the glands, causing dry mouth and dry eyes. The vast majority are positive for anti-SSA antibodies. Well, this particular patient was persistently positive for anti-SSA antibodies. What this tells me is that the immune system did not normalize in every single patient. This patient still had some bad autoreactive B cells surviving. So it tells me that this particular type of CAR T cell therapy called CD19 CAR T cell therapy, it may not work for everybody. Could it maybe not be the right fit for people with Sjogren's disease? Could it be not the right fit for 1/3 of lupus patients who are positive for anti-SSA antibodies? Well, we don't know the answer, and this is one thing that researchers are going to have to figure out. Which B cells should we be getting rid of to help out which patients? Every lupus patient has a different type of immune system, and can we figure out which parts of the immune system are more abnormal and target those instead in individual patients? And I think we can figure that out. So at this point, I'm going to go dive deeper into the science and the medical part of how B cells work and stuff. But just to simplify it for those of you who may not want to think too hard about the science, to put it into basic terms, CAR T cell therapy is where we're taking your T cells, we're taking them out of your body, we're engineering them to destroy your bad B cells and put them back into your body. And then your bone marrow starts to make good B cells again and put you back into a healthy state where you don't have to take any medications and put you into remission. But the question is, which should be our target? There's lots of different types of B cells in our body, and this shows us the progression from a pre-B cell to the most mature called a plasma cell. So inside of the bone marrow is our stem cells, and they make these pre-B cells, which become immature B cells. They go out into the blood and the lymphatic system and become transitional B cells, follicular B cells, memory B cells, which are very mature B cells, and then plasmablasts, which become plasma cells, and then they can go back into the bone marrow and live a long time. Every single one of these types of B cells, by the way, has different badges or different antigens. I can tell the difference between a pre-B cell and an immature B cell by simply which antigens or badges are around them, and we can make T cells that target these different types of badges. Now, I'll point out a couple of these different B cells. Memory B cells are very, very mature. For example, and they're very, very important. For example, let's say we give you the pneumococcal or the COVID vaccination, and your immune system learns how to make antibodies against those. Well, it actually makes memory B cells that can recognize the pneumococcus or the COVID bacteria, but it's not making antibodies. It's just kind of floating around in your body, and there's trillions of different kinds of these, by the way. And then it finally comes into contact with an invading COVID virus or an invading pneumococcal virus, and it says, oh, that's a foreign invader. I'm going to start making these antibodies. So it starts making antibodies to identify them. It starts to replicate and multiply as it makes other B cells become active and T cells so it can fight off the foreign invaders. Very elegant. But then there's also these plasma cells. Plasma cells are the most mature B cells, and they're constantly active. Each one makes a different type of antibody, and they produce around 2,000 antibodies per second. Just think about that. In just 10 seconds, one plasma cell can make 20,000 antibodies. And then there's millions to billions of these plasma cells throughout our body. So that's just amazing, and they can be immortal. And just think of that, these plasma cells, so they can make the antibodies like to the pneumococcal vaccine or the COVID vaccine and keep making them. And that's probably where the sources of those came from, because they weren't getting rid of plasma cells with the CD19 type of our CAR T cell therapy. And now let's look at how the different antigens or different markers work. So the 8 patients who received the German patients who received the CD19 CAR T cell therapy, these are the types of B cells that have CD19 on them. So it got rid of all of the pre-B cells through the memory B cells and plasmablasts, but it left untouched those plasma cells, and that's why they were able to respond to vaccines. Well, let's look at another one. There's another marker called CD20. It's actually on the same types of B cells as CD19. And by the way, this is actually how rituximab or rituxan and obinutuzumab works inside the body. So they destroy these, but they leave the plasma cells and the plasmablasts alone. And then there's another type of one that you're going to see, and in my blog post, I talk about this one as well. There's another type of badge or antigen called B cell maturation antigen. We call it BCMA for short, much easier to say. Well, BCMA is only found on the most mature B cells, plasmablasts and plasma cells. And so there are some CAR T cell therapies out there that destroy those, but leave all the other B cells alone, and they do work. And the question is, which type of CAR T cell should we be using in any one particular type of patient? Because we can make these CAR T cells bind to any type of antigen and destroy any type of cell that we want to. So there's a CD20 that's a possibility. CD19 is being used by the German group. There's one in research right now that wants patients. So if anybody of you out there has severe lupus and not responding to any therapies, there's one called Descartes 08, which targets the BCMA. They're starting to do research on it, and it's been shown to be helpful in myasthenia gravis. And then there's a Chinese group that has treated a lot of patients so far with a type of CAR T cell therapy that binds to BCMA, but also to CD19 as well. And I'm going to talk about those patients in just a little bit. These are just 4 examples, by the way. There's lots of other targets that we can go after. So again, why do these CAR T cell therapies work better than the B cell targeting drug like Benlysta? Well, it's because the medicines don't deplete the tissue B cells. Those tissue B cells, they're still alive inside of the joints of the body, causing arthritis, the lymph nodes, the heart muscle, the brain, and so forth. And so that's why CAR T cell therapy works better, because it goes into the tissues. So again, at this point, we have had reported 22 lupus patients who are in drug-free remission. two of them now for close to 4 years, and those two are actually Chinese patients. We talk about these 8 German patients all the time, but at our American College of Rheumatology meeting, a Chinese group, they showed that they had treated a large group of patients starting way back in 2019, and those were actually the very first patients ever treated, and they used the BCMA with CD19 targets. There's 2 other additional patients that I mentioned earlier that were close to remission using a drug company called Novartis, and they had used their drug is called YTB323, and it's a CD19 type of T cell therapy. Now, like I mentioned before, we're afraid of the possibility of infections. From day 19 to around day 90 or 100, there's no B cells whatsoever. That's when they start to come back, is around the 90th day. And so we're afraid, could they be getting bad infections? Well, we have to remember there's lots of other types of white blood cells in our body that can fend off infections, like T cells and neutrophils and other types of lymphocytes. And so interestingly, there were no severe infections reported in any of these patients who received the CAR T cell therapy. One Chinese patient had a urinary tract infection that required hospitalization, but otherwise, and recovered very well from it. I will have to say, though, someone reached out to me on social media. It was a personal communication, and she told me that she knew of one of the CAR T cell German patients who ended up getting a severe infection and had an intensive care unit admission. You can't always trust everything on social media, though, but this particular person has a PhD, and she seems to be very responsible and trustworthy. But so we have to keep this in mind. Even though the researchers put certain data inside of the research studies, what happened after that time period, they could have still been had the potential risk for infection. So this might have happened, I'm not sure, but I just wanted to include that in my talk. There's also a possible side effect called cytokine storm, or the proper name is cytokine reactivation, and I'll explain what that is. These CAR T cell therapies, by the way, they're originally designed to treat B cell cancers. So B cell cancers like B cell lymphoma, these CAR T cells, they destroy all the patient's B cells to include their cancer cells. And back in 2016 is when they started to become available. A high percentage of the patients, we get this bad side effect called cytokine reactivation. And what that means is, just think about it. The CAR T cells, they're multiplying and replicating inside of the patient's body, and then they're destroying the B cells. And throughout this whole process, the immune system can become overactive, releasing cytokines, which are how white blood cells tell each other to become more active. And they saw this happen in some patients. You might remember hearing this term cytokine storm, by the way, which is a type of cytokine reactivation. It was the major reason that many patients with COVID infection ended up dying. And we figured out that there was a treatment for it called Actemra, or tocilizumab, and we do use that still to this day with severe COVID infections. If someone gets this cytokine reactivation from COVID infection, we give them this Actemra, and that's how we treat it with CAR T cell therapy as well. And fortunately, the vast majority of patients do not die from cytokine reactivation syndrome, but it can happen. But it fortunately did not happen in any of these 24 patients as far as severe cytokine storm reactions. And there were no severe neurological side effects, which we do see in the B cell cancer patients, by the way. And we think that those two side effects, by the way, the cytokine reactivation and the severe neurological side effects, we think it has to be related to what we call the B cell load. There's a lot more B cells to kill in someone who has a B cell cancer compared to a lupus patient. Lupus patients have markedly less B cells. And so we think that that's the reason why these particular side effects may happen in cancer patients, but not in our lupus patients. But we still need to look out for these possibilities. Now, I will have to say that there is one type of CD19 therapy by Novartis. I mentioned it earlier, called YTB 323. They have reported on 3 of their patients, and 2 of those patients did get cytokine reactivation syndrome, but it was very mild, and they both responded to Actemra. But the patients who received all the other CAR T cell therapies, none of them had this cytokine reactivation syndrome. So that's reassuring that it's not nearly as bad as what we see in patients with B cell cancers. Well, how about other autoimmune diseases? Any autoimmune disease where B cells are overactive and causing autoantibodies should be helped by this CAR T cell therapy. And so they have tested it in other patients. There's been several scleroderma patients who went into remission with the therapy, several myositis patients, a severe form where it attacks the muscles, and they went into remission as well. There's patients with myasthenia gravis. These patients get horrible weakness and can die from muscle weakness. And 14 patients were treated with a type of CAR T cell therapy called Descartes 08. It targets BCMA, as we mentioned earlier. The interesting thing about this particular CAR T cell therapy, though, is that they use RNA instead of DNA. CAR T cells that have DNA in them, they replicate inside of the person's body when they're put inside of them. RNA, which is ribonucleic acid, it doesn't cause the cells to replicate or multiply. And so because of that, patients who receive this type of CAR T cell therapy don't need chemotherapy. And that's a positive for this particular type of therapy. Also, because they're not replicating inside or dividing inside of the person's body, they also don't see the cytokine reactivation syndrome or the severe neurological effects. So it really has some positives into it. The myasthenia got much better in every single patient, but what they saw is that the antibody levels do start to come back at the 9-month mark. So far at the 12-month mark, they did not see the myasthenia gravis get worse, but the doctors using this therapy think that probably because of this, the patients will need to have ongoing therapy over time. But it has some positives. They don't need the chemotherapy, so there's less risk of infections. They don't get the cytokine reactivation syndrome. So there's a trade-off. They do have to get repeated therapies, but maybe at the good thing of not having as bad as side effects. And we'll talk about other side effects in just a bit. So what are other possible side effects with CAR T cell therapy? Well, we know that there's others. For example, in the myositis patients, and by the way, the patients who had myositis, which is inflammation of the muscles, they were treated by the same German group and the same CAR T that the lupus patients got. But these particular patients, every single patient did get side effects that were not seen in the lupus patients. All 3 patients treated with this myositis did develop this cytokine reactivation syndrome, but they all did respond to tocilizumab. 2 of the 3 patients developed the neurological complications. They had developed balance problems called ataxia, but they resolved on their own after a week. So there's something different about myositis patients, and it probably has to do with the muscles being intricately involved and attached to the nerves of our body. Maybe that's why. But we can see that not all autoimmune diseases are going to respond the same as far as side effects to these therapies. So these are things that we're going to have to figure out in time through good clinical trials. And there are clinical trials going on for all of these diseases at this point. Other potential side effects: when you get rid of B cells make those antibodies. Another name for antibody is gamma globulins. And so when they become low over time because of less B cells, patients with CAR T cell therapy can get low gamma globulin levels or hypogammaglobulinemia, and this can potentially cause infection. So this is something that will have to be monitored over time. Even though we didn't see severe infections in those 24 lupus patients, could that be a possibility after the time period that has been reported so far? We don't know for sure. And then, how about cancer? This is an important topic. Back in November of last year, the FDA, they put out this black box warning on every single FDA-approved CAR T-cell therapy that we use for B-cell cancers. The FDA stated, we have become aware of the risk of T-cell malignancies with serious outcomes, including hospitalizations and death following treatment with both BCMA and CD19-directed genetically modified autologous T-cell immunotherapies. And by the way, those last 5 words, it just means CAR T-cells. So it's just a very fancy way in medical terms of saying that. So these therapies can cause cancer. And why is that? How does that happen? It's helpful if you know why and how, so we can talk about how this might not happen with some CAR T cell therapies and it may with others. Remember, we have you come into the clinic, we give you this chemotherapy to get rid of your white blood cells or most of the white blood cells, then we give you those CAR T cells into your body. Those CAR T cells go and they replicate throughout your entire body. And just think about it. What if one of those CAR T cells decides to become cancerous and multiply over and over and over again? Remember, these are T cells. Another word for T cell is a T lymphocyte. And when there's a cancer of these T lymphocytes, it's a T cell lymphoma. So we call these CAR T cell lymphomas. They're actually lymphomas that are made up of these CAR T cells. Now, this is a rare side effect, by the way. There have been over 30,000 patients treated with B-cell cancers since the year 2017, and they've only seen a few of these CAR T-cell lymphomas occur. So it is rare, but it has been seen with each of the FDA-approved therapies. And so it does seem to be what we call a class effect by the FDA. Now, in someone with B-cell cancer, this is perfectly acceptable. These are patients who are going to die. Patients who had failed every single therapy, and many of these patients are in remission, which is just phenomenal. And so, it is worth it in these particular patients who got the CAR T cell therapy who have B cell lymphomas. But we have to think about it. Is CAR T cell therapy worth it in autoimmune diseases? Our patients are living a long time. Kelly, look at how amazing she's doing. She's had severe systemic lupus and she was 11 years old. She's probably going to live a long, normal lifespan. I have a couple of patients now in their 90s, quite a few in their 80s. And so do we want to expose them to the possibility of a CAR T cell lymphoma over that entire time? Makes me think, and it should make you think as a patient. And then how about infections over that long length of time as well? Are we exposing you to these types of problems, and is it worth it? And then we've only been following patients for a few years. Are there other unknown side effects that could occur at the decade mark or at 2 decades? And we really don't know. There's a lot of unanswered questions. And so one question is, should CAR T cell therapies be restricted to only those people who have B cell lymphomas or leukemias, because it's worth it, if only a few people get CAR T cell lymphoma, but it saves many lives, that makes a lot of sense. Well, we can actually make CAR T cell therapies that do not cause CAR T cell lymphoma. And so that's a good thing. That is a bright lining. For example, I mentioned Cartesian's Descartes 08 CAR T cell therapy earlier. That's made with RNA instead of DNA, and it targets BCMA. These do not replicate inside of the person's body. So it can't make CAR T cell lymphomas. So we do have CAR T cell therapies that can actually be used that don't do this. Because when we give the person these RNA types of CAR T cells, those CAR T cells, they disappear over time. They don't replicate. They cannot become cancerous. But the downside of this type of therapy, though, is that repeated treatments are needed. We don't know how many. It may be just one infusion a year, could be a couple of infusions a year, but it could be well worth it if it caused drug-free remissions for a long length of time. So just something to keep in mind. These are just questions that we have. So some of you watching this, do have severe systemic lupus. Some of you watching this may not be responding to many therapies. I have a few patients in my practice who have failed every single therapy. If you think that you might be a candidate for CAR T cell therapy research, and we need you as to figure this out, without therapy, what is your future going to be like? It could be worth it to get this type of therapy. And we have 22 patients already in remission. You can learn about these clinical trials at my website, lupusencyclopedia.com. You can freeze it right here to get the exact website for my blog post that talks about, it goes into detail about CAR T cell therapy, and it mentions all the clinical trials and also the contact information for those clinical trials. Or just go to lupusencyclopedia.com, and in the search engine put in CAR T, and you'll find that particular web page. So what is the future for CAR T cell therapy? We're coming close to the end, and then I'll be glad to answer any questions. Number one, will larger studies reproduce the results that we've seen in these fewer, smaller studies? Because we have to have larger studies. They have to be well-designed clinical trials. Then how long does remission last? We know it lasts for a few years, and these patients are very happy. And by the way, remember Dr. George Shett I mentioned earlier, who showed the data from those 8 lupus patients at our ACR meeting in November. He showed a photograph of those patients, and they were all smiling and happy looking, all of them on no medications for their lupus whatsoever. I mean, that's just mind-boggling, and that just gives us some hope. But how long does that remission last? We don't know. And could there be more side effects that we don't know about yet in the long term? And then which patients should get which type of CAR T cell therapy? We can make all kinds of different CAR T cell therapies, and I talk about those in my blog post. I think we need to figure out the immunology of each patient and then give them a designed CAR T cell therapy that is specifically for them. For example, those patients with anti-SSA antibodies, CD19 may not be the best one for those. And then how about other diseases like Sjogren's disease, rheumatoid arthritis? By the way, I'm a little nervous about Sjogren's disease. Sjogren's disease patients have a lot of B cells, a lot more B cells than lupus patients. So we have to be careful with them. We don't want them to get those bad side effects I mentioned earlier. So maybe therapies like Descartes-08 that don't replicate in the body, maybe those might be a little bit better since they don't cause those side effects dependent upon the B cell load. And then should we give CAR T cell therapy to only our sickest patients? That's a big question. But could we give CAR T cell therapy to patients with milder disease? And that's a possibility. Why do I bring that up? Well, let's just think about it. Let's say that someone like Kelly develops lupus at 11 years old, gets under great control, and then just has mild systemic lupus, but lives for 70 to 80 years. There was a study that came out from Johns Hopkins just a few years ago that showed that even patients with mild systemic lupus on average cost $20,000 a year on average to treat their lupus. So if we give them a therapy that costs $100,000, and that's what CAR T cell therapy costs, about $100,000, if it causes remission for a very long time, all of us can easily see how that would be cost effective for that patient, plus on no medications. And then many patients take such expensive medicines like Benlysta and Rituxan that the average cost for those patients can be in the close to $100,000. And then should we only be using CAR T cell therapies that don't cause lymphoma? That's a very important question for us to answer. Well, this picture here, I like to have this as a representation of one of those Chinese patients. The first Chinese patient was treated actually in 2019, and then another one was treated very soon after that. Those two patients are close to 4 years in remission. We like to talk about the German patients being over 2.5 years, but these two have been close to 4 years. This is not actually their photo, but this is one I found on the internet. So CAR T cell therapy is fascinating. I've never seen a therapy cause 100% of patients go into remission with very low side effects. So we're all excited about this. The clinical trials are starting. Could we possibly have this as a possible true therapy in our patients in a few years? It's absolutely possible. And I'm open to answer any questions that you might have for me at this time.
Wow. Well, first of all, thank you for such an extensive presentation with layers of information. My head is swimming. I had questions before. I have more questions now. I know I want to be very honoring of your time since you just pretty much spoke for an hour. So I'm going to try and talk fast, and anything that we don't get to, maybe we can do it through an email exchange and get some more information when you have the time.
I have time. I have time, Kelly.
Oh, you're so wonderful. Thank you so much. So, obviously we've heard now how it works, the behind the scenes, the research, but as a patient, from a patient perspective, I'm very curious how it feels. Um, the discomfort of going through this process. I think these are the things that may hinder someone from enrolling in a clinical trial. When you are without B cells, all your B cells are gone. How do you feel, Dr. T? You feel tired? Is it painful?
I would think that probably people feel tired, and that information was not put into
Mhm.
the data that they reported in their research studies, by the way. But I can say this. As I mentioned earlier, Dr. Shett, he showed the photographs of those particular patients, and
Mhm.
all 8 patients had these huge smiles. It was just how a picture can paint 1,000 words, and
Right.
his very words were that each of those patients was having an amazing quality of life on no medications, and you could see it in their faces. Actually, I know in my own practice, most of my patients are in remission or low disease activity,
Mhm.
and many of my patients don't have big smiles because they're dealing with having to take all
Yeah.
these medicines. They're expensive, having to see the doctors all the time. And so that really takes a toll on you. So
Yeah.
I think, I don't know. I don't know for sure, but boy, they sure seemed happy.
Yeah. And I know it's about the end game, but it does seem to be pretty intensive from a patient perspective. I'm just playing devil's advocate here, thinking about not just the price of it being expensive, but the immune ablation, having your immune system completely taken away. Um, do you feel that the risks are worth the rewards with CAR T?
So far, it looks like it. Of course, we need to see more patients, but I mean, that's a lot of patients. And what is fascinating is that the researchers had the same fear, by the way.
Mhm.
But what they showed, first of all, over 30,000 patients with severe B cell cancers have received these therapies, and most of them do not get severe infections. So that's the backdrop for this.
Yeah.
And then you have to remember that we're not actually getting rid of the entire immune system. Even though we're getting rid of the B cells, we still have all those macrophages, those monocytes, those neutrophils, those dendritic cells. All of these are different types of white blood cells that attack viruses
Mhm.
and bacteria and keep us safe. And then there's the plasma cells, the most mature B cells for the CD19 type, at least, that is still attacking or be able to protect us against infection. So somehow the immune system is working.
Okay. The patients that were in the study that had severe disease activity, did some of them, all of them have lupus nephritis or end-stage renal disease? And were they on dialysis? And how does the dialysis work if that was the case with this type of therapy?
Great question. All of the patients in the Chinese study and the German group, all of them had severe lupus nephritis. That was a requirement for the studies. It's just very easy to treat patients with lupus nephritis. That's why. And now, as far as end-stage kidney disease, I don't know. I don't know if any of them had end-stage kidney disease, and how patients with end-stage kidney disease. And what that means for the viewers is that's patients on dialysis. So I can't answer that question, unfortunately.
Yeah, I know we have people in our community who are on dialysis, and we're wondering about that. You know, looking at the timeline of the 3 weeks coming off your immunosuppression therapy, I wasn't sure if hydroxychloroquine was going to be included in that or not. So thank you for answering that question, because I know it's sometimes considered an immune modulator, but it does fall into that category of immunosuppressant. That's, I would assume from my perspective, and this is my opinion, that's a pretty that's a big challenge to take on, knowing you've got 3 weeks to come off all of your immunosuppressive therapies, including getting under 10 milligrams of steroids.
Let me just specify something. I do have to
Yes,
say
please.
this, that in all these research studies, actually, they did not mention whether they stopped the hydroxychloroquine or not. So that's just kind of an assumption. But you're right, it's not actually an immunosuppressant. So the question is, did they stop the hydroxychloroquine? And we think they did because every study is saying that the patients are in drug-free remission. So
Yeah.
drug-free means no hydroxychloroquine as well. So when they stopped it, was it 3 weeks before
Mhm.
they started their therapy or not? Unfortunately, the researchers didn't say 100%. I wish that
Mhm.
they did.
Yes, yes. It seems like, and this once again is just my assumption, that this therapy might work best for those who are newly diagnosed with severe lupus. Um, my brain goes there because I think of a lot of us who are steroid dependent, and I'm curious how those of us who are in that camp would be able to even attempt to come off of um, or 10 milligrams of steroids, or get to 10 milligrams of steroids for to be considered for this process.
The first two patients who were treated, Kelly, in China had severe systemic lupus for over 20 years. So
Really?
they absolutely do respond, but there is a big
Oh,
difference, by the way. Unfortunately, patients who have had lupus for a long time oftentimes have permanent organ damage. In fact, the
yeah.
vast majority do. So just think about it. Those who have permanent joint damage, they're still going to have joint pain, even though we get them into complete remission. So
Mhm.
and we have to think about that about every organ that's involved. If it attacked the eyes, they're still going to have some blurred vision, et cetera. So the permanent damage won't be reversed, but there's hope for the disease itself.
Yeah, yeah. And the timeline as well, going back to getting prepared and the hospitalization and receiving the medication and then the check-ins, that's a big commitment with this therapy of changing location to be close to the therapy site. um, do you think it's sustainable for those with families and jobs and dependents to, and not just sustainable but even affordable to the majority of people who are affected by this illness?
Sure. So first off, we're going to get easier therapies to give. The Descartes O8 that's made with RNA, it's actually given in the doctor's office. It's not in the hospital. The other ones that we were in the research studies were given in the hospital and were definitely
Mhm.
more intensive. So there are CAR T therapies out there being developed where you can just get it in your doctor's office, like getting your rituximab or your Benlysta, for example.
Wow.
This is much easier, because you get
Yeah.
much less infusions. As far as cost, like I mentioned, if we demonstrate that we can get very, very long remission rates, and $100,000 can be much cheaper than a couple of decades of medical care, a lot less. Insurance companies I could see definitely jumping on board.
Oh, wow. That's fantastic. Um, I wonder if okay, so I'm going off script here a little bit with my questions, but there was such hesitancy with the COVID vaccine, which people thought altered their DNA. And so a lot of people thought that it was dangerous. We know that's not true. We know it saved millions of lives. But do you think there might be a little bit of a reluctance with patients to try CAR T because it actually does genetically modify your DNA, and you are being essentially infected with the virus that that is intended to stop your overactive immune system. Yes, but do you think there might be some reluctance there?
Oh, Kelly, you have a good crystal ball because you know that's exactly what's going to happen on social media. There's going to be people
Mhm.
saying exactly that thing about how we're engineering these T cells to change all the DNA in someone's body. I know it's going to happen, and unfortunately, we can't control that. So hopefully, if we keep educating people, the actual science and medicine behind it, hopefully, when you see results, that's really the final thing. But people are going to believe what they believe. There's a lot of misinformation out there, unfortunately.
Yes, yes, and hopefully doing more things like this will increase health literacy and debunk those myths. And I'm very intrigued about the Sjogren's antibodies and that connection there. Um, I guess my question in this is probably, I don't know if this makes sense the way I'm stating this, or if you can even answer this, but um, if they, if SLE patients that also had Sjogren's overlap tried CAR T therapy and it didn't deplete all of their B cells or their SSA, SSB cells, right? Is the fear that those antibodies that still exist could reproduce and hypothetically undo the work of the CAR T therapy?
Absolutely. That's why we need to figure out which CAR T cell therapies
Wow.
are best for which patients. But I will mention that that the Chinese group, remember they used CAR T cell therapy that had both that attached to both BCMA and CD19. So they get rid of all the B cells from the pre-B cell to the plasma cell. And they
Mhm.
actually mentioned in their research article that all the auto antibodies completely went away. So we have to think about that. Probably a third of their patients were anti-SSA positive, so they were able to get rid of it. Another fascinating type of CAR T cell therapy, though, is that Johns Hopkins, they developed this one using what we call CRISPR technology, where they could insert a particular type of DNA into the T cells and not use
Mhm.
viruses and stuff. Fascinating. But these CAR T cells only attacked one type of B cell. They attacked a B cell that was making an antiphospholipid antibody. So we can make a CAR T cell that attacks B cells that only produce anti-SSA. So there's a lot of
Oh,
possibilities out
wow.
there, and we're already seeing them in research studies
Wow.
and real patients.
I just have like one more question, then I want to acknowledge people that are here that have been waiting so patiently. Okay, so we know that statistically lupus primarily affects women of color, mostly Black and Hispanic women. And in these trials, I see one in China and I see one in Germany. Has there been women of color, particularly Black or Hispanic women, in these studies at all? Can we see how it impacts those ethnic groups?
Sorry, that's my dogs.
That's okay.
My little barker stopper here. Uh, so, anyways, yeah, that's a great question. My suspicion is that they didn't say the races or ethnicities of all the patients, but probably a large percentage of them. Well, of course, they were a large percentage Asian, so
Mhm.
they were non-Caucasians because all the Chinese ones would have been that way. Sorry about that. And then unfortunately there's probably low number of African American patients or people of African ancestry in Germany, for example. So
Mhm.
it hasn't really been studied in that patient population, and that's why we need patients of African ancestry and Hispanic ancestry and Native American ancestry to please join in the clinical trials, because we need to learn that. And by the way, I want to give a shout out to our Native American and Native Alaskan patients out there. They have the highest prevalence of lupus out of everyone, and we keep forgetting them. But I'm not forgetting you.
Wow, wow. Thank you for saying that. Absolutely. We have a lot of people joining from all over the US and Europe today. We've got Chicago, we have New York, we have California, we've got everybody here, East Coast, Connecticut. A lot of people are saying if I could sign up today, I would. is very, well, let's see, let's see, there was a couple of good questions. Yes, if someone's asking, would CAR T do anything for Sjogren's and RA? I think you've already addressed that. We've linked your website here for people to get more information. Let's see. CAR T specific questions. Okay, it says, how long is remission expected once achieved? And if lupus returns, is there any prediction on if it will come back in a more aggressive form? That's a good question.
Yeah, we don't know the answer to that, but when we look at B-cell cancer patients, they do retreat them and they do respond. So that I suspect that's probably what would happen.
Let's see here. Yeah, that people are saying, a lot of our medications we take currently have a cancer risk as well, albeit low, but, like azathioprine. So, we're already on medications, I guess, that increase on some level. Let's see here. I have SLE and subcutaneous lupus, and it's severe. Is there any hope that CAR T cell therapy could help with the severe skin issues as well?
Absolutely. We divide it into cutaneous lupus and systemic lupus. Kelly, guess what? Desiccated lupus or cutaneous lupus is systemic lupus. It's just a milder form that primarily affects one organ. But we know that those patients with only cutaneous lupus, they still have an increased prevalence of heart attacks and strokes because of the systemic inflammation and the inflammation of the blood vessels. So many of us lupus experts, we don't like the term cutaneous versus systemic. Cutaneous is just a milder form of systemic lupus.
Absolutely. Absolutely. Okay. Oh, we've got Australia joining as well. Does this therapy seem to work with pediatric patients? Why or why not?
Great question. And of course, pediatrics always falls behind adults, because just think about it. How many parents are going to subject their child to a completely unknown type of therapy? So that's not being done, but I can absolutely see it being done, because our children get the most severe lupus, as you well know, Kelly. So and think of all the children who get leukemias and lymphomas. That's their primary cancers they get. And there's such a high rate of cures these days. So they will be treated if it shows that it's effective.
Random question that just popped into my head. You mentioned HIV being a particular type of virus that of the same family of virus that they're using. Is Epstein-Barr virus in that family as well?
I don't think so. I don't think that. No, it's not a lentivirus.
Lentivirus.
But I don't remember the exact large family of Epstein-Barr virus.
Okay. Oh, this therapy gives us so much hope. Looking forward to the research updates. Thank you, Ming Sun, for posting the direct link as well to your blog on CAR T therapy for lupus, Dr. T. And I think anything else very prevalent, I will send your way if you have the time to look at it later. But I just want to say thank you so much for this informative presentation.
And just remember, everybody, knowledge is power. Every single person who's here, you're going to do better from your lupus simply by learning more. So keep learning. Go to my website, learn how to take care of your lupus better, and you're going to have such a much better future.
Yes, absolutely. Wow. Thank you. And as always, check out morethanlupus.com for any updates. And Dr. T does posts for us on Saturday called Ask Dr. T. So maybe we can take some of these questions and add those into the queue for those upcoming posts.
And please, if you haven't, More Than Lupus, great charity organization.
Oh, thank you. And if you haven't done so already, there we go. Get yourself a copy of the Lupus Encyclopedia, now in its second edition, on Amazon. You can go to his website as well. As you can see, I love mine. I have many of my favorite new editions tagged there. Every lupus patient should have this, or if you know someone who has lupus and you want to learn and support them, this is the best way that you can do it, is by reading this book. So please visit the Lupus Encyclopedia for all of Dr. Thomas's latest and greatest research updates and blogs and events. And it's been a privilege and an honor. Thank you again, Dr. T.
Have a great weekend, everybody. Bye.
Thank you. Thank you guys for joining. See you next time. Bye
All right.
now.